On this, our objectives are going to go through some common reasons why we might want to taper people off of their opioids. I also included a few slides here on benzos too, because I think there's a lot of parallel with the two, and trying just to kill two birds with one stone here. And then a lot of this really comes down to is being able to communicate effectively with our patients, and then learn some basic concepts. So basically taking this from the 2022 CDC guidelines on pain that have been or in 2016, and then the revision in 2022, I've really set some standards that we look at. And basically, I think some of the weaknesses of the guidelines, and especially the 2016 ones, is really getting good, safe ways to taper people down. I think in 2024 that we're far more likely to inherit a patient who is on a high dose opioid or high dose benzodiazepine from another provider than we are, and getting our up to those higher amounts, and recognizing that some of the literature used in the CDC guidelines is really based on people initiating oxycodone and other opioids. So just as in the echo style, doing a case is starting with Mr. T, as a 54-year-old male who presents with a history of chronic low back pain, who's new to our practice. And he presents, he's on oxycodone and acetaminophen 4 times a day, plus morphine, sustained release of 30 milligrams, three times a day. He has some complaints of some significant constipation. He's got a history of obstructive sleep apnea, and intermittently will use a CPAP. He is not on any adjunct treatments. His PDMP is appropriate for his patient, and his urine drug screen is positive for oxycodone, and opiates only is negative for 6-MAM. Maybe this is a little bit dated, or instead of 6-MAM, which is pathognomonic for heroin, is negative for fentanyl. And so I think, at what point should we consider an opioid taper with this gentleman, and how might we communicate that opioid taper with the patient? So as far as with the benzodiazepines, and we know that long-term use of benzodiazepines over 120 days is generally considered risky. Really, there's not a lot of benefit in benzodiazepines in handling things like anxiety beyond a month. When we give benzodiazepine for PTSD, we actually, in most studies, we actually worsen their outcome. So again, something necessarily to be avoided. The other thing that benzodiazepines do is they really mess with the brain and really trick the brain into feeling that they need it. And I think, my patients teach me a lot. And I had one of my patients that has told me where to go in much more colorful terms than that, more than once, as well as pretty much everybody at the UNM's addiction clinic. We were rapidly tapering her and her significant other off of benzos at the same time following an overdose. And then there was clearly sharing and some other unsafe practices. And, when we were told off, and seeing them on an almost a weekly basis. But when we got her to the point where she they were off the benzos, and being able to see them again in clinic, and to their credit, sticking with the program, I was waiting to be able to ask the question, so as it was so rough for you, and you were in that, and now you've got a moment of clarity, and you see that the benzos weren't helping you as a physician, how can I tell that story to other people, and how can I share that? And her answer was, there's no way you can. There's no way when I was there, between my husband and I, we ever could have been convinced that our life would be so much better off of benzodiazepines. So just keeping in mind and how powerful that trick is in the brain is something that we're going to need a lot of support for our patients, and really is that's kind of cements into a bit of my cornerstone of my approach. All right, the other thing with benzos is rarely do we have a benzo use disorder by itself. There's usually a co-occurring substance use disorder, whether it's alcohol, it's an opioid, it's a stimulant, it's almost always co-occurring. With benzos, again, we get some worsening depression. We have it's on the Beers list, increased risk of dementia and a whole bunch of other things. So again, long-term use isn't relatively there. So yeah, as far as when to consider tapering an opioid, I think one of them, and the most common, is actually going to be the patient requesting a reduction. Most patients don't want to be on high doses of opioids or a high dose of benzos. And you can ask them, more as a hypothetical question, do you ever wonder what your life would be like without being on that? And some of the insight that they will come to. Oftentimes, patients who have an underlying substance use history will say, "No, I can't imagine that life. That's going to be really hard to imagine." Others are like, "Man, if I could, I've tried a variety of things to get off of my oxycodone, and I just can't do it." Those are ones that we start looking at too. So if they start having a substance use disorder, like, let's make that diagnosis and start treating it. And I think in 2024, and appreciating everybody on here, and our new friend in Mississippi, a big shout out to you, because this isn't your first or second session, and hopefully that you're finding these helpful. As this is finding their way into primary care and getting the referral to somebody like Sergio or I, who we do addiction care, just making that phone call to an addiction doc and showing up is a big deal for patients. And there's a lot of people who never follow through, but being able to show up to our primary care clinic and our primary care people and being able to start this, I think, is a huge, huge help. If they show signs of immediate risk or harms on themselves, those are people that we might look at detoxing a little bit quicker. If they're not having a meaningful improvement in their pain score, this is one of the things that the CDC also identifies. And I think this is one of those where we can talk with the patient is like, look, going up on a dose of your opioid or going up on your dose of your benzo has worked for a week or a month, but then after that, it doesn't work more. And so my concern, and I've seen this a bunch of times, is we could go up on the dose and it's going to work today, tomorrow, but in a month, it's not going to work. And it's going to just create more problems down the road. We need to start looking at other avenues. This is a Snehal bot slide, but asking the question internally, where's the motive coming from? And are we looking to do this in the benefit of our patient? I think we as human beings, we have a unique way of thinking, and if we're starting to think of the patient as a good patient or a bad patient, a patient we like or we don't like, if this patient deserves medications, can we trust the patient? Should the patient be rewarded? All those things are ones that we should be checking ourselves for internal biases for the patient to do. This is one of my favorite slides of this talk is this is a balancing act, because coming down on opioids, and what I like about this one is this is a full-on JAMA publication looking at 113,000 patients and looking at on opioid tapers over a 10-year period of time, and the outcomes were a risk of overdose and mental health crisis, basically defined as showing up to the ER with Dr. Steinberg. He's one of the ER faculty here that I enjoy working with very much. And Dr. Steinberg sends them and gets an inpatient admission to psychiatry, is really what they're defining as a mental health crisis. And they found that both were statistically significant while we're beginning the taper. So this is not a benign thing. What didn't make the paper and has made headlines is there have been physicians or healthcare people that have been threatened and even killed over not prescribing continued medications. So I think as far as the tapers go, and with opioids, a rapid taper oftentimes isn't the best way to go. And we've got to support patients through this, to educate and to allow and to know that they're have some underlying psychiatric symptoms that are present. So if they just lost their dog or a relative, that might not be the best time to start with the withdrawal. There are, as life goes on, and as we increase our number of years on this earth, we appreciate the wisdom that we have, and that there are ups and downs of life. And sometimes we just need to ride with some of those roller coasters in that. The higher success rate, especially with the benzos, is usually months or even years and tapering down. And in some patients, we just can't always get all the way off. And usually a good goal is 20 to 30% over a course of a month. I personally start a little bit slower than that and go up. So my goals of tapering, and this is how I kind of what I think about is, first of all, I've got to have the patient on board. The access to benzodiazepines that you can source illicitly or quasi-legally online on the surface net is a huge market. Your patients will not have problem finding a benzodiazepine if you don't prescribe it for them. Same thing with an opioid. They don't have a problem. They will find an opioid. And if they struggle, there is somebody on the street that is more than happy to sell them and get them down the direction of an opioid use disorder. So again, this is a time when getting the patient on board, again, I think is really important. Maximizing their non-opioid analgesics. And there's a whole nother talk on pain control, on anxiety control that we can do that doesn't involve a controlled substance. We want to work on to inform the patients on what withdrawal symptoms look like, and so they can recognize, because being a male, maybe not the best example, but giving natural childbirth is described as a very painful experience. Women get through it all the time. They don't know how they're going to get through it during the natural birthing process, but having pain meds and things, it's all worth it in the end, but we know we have a finite time frame. And so if we start giving people, hey, that's probably some withdrawal, and you're just going to have some of that withdrawal. And if it gets to be too much, go ahead and here's how we're going to abort it. But just knowing that it's going to get better in a day or so, oftentimes is all the patients need to know ahead of time. Conversely, if they're struggling with the withdrawal, I won't, as their prescriber, as their physician, I want to know about it so that I can make changes, I can address it appropriately before they start going to, I don't know, for lack of a better term, the dark side. It is May, and May the 4th was, or National Star Wars Day was like last week, right? And then I like to give the patients a lot of control over their tapers, namely because I'm impatient writing prescriptions, and if they're on 100 morphine milligram equivalents a day, a 10% decrease is easy to 90 morphine milligram equivalents a day, and I keep going down. But my patients are never on a nice round number like that. And so what I find also is helpful is giving a patient what I think is a good reasonable number, and oftentimes it's their normal amount this month, and then at the end of the month I've instructed the patients to pick 10 doses or a dose or two a week when their pain's either controlled or their anxiety is controlled, where they can skip the dose and to see how they do. And that makes it, I don't know, for a lazy physician like me, just easier to write the prescription. But it really, more importantly, it really empowers the patient to know that they have control and to trust that they have the drug there for a bad day, that I'm on board with them taking it on that bad day. But when they have a good day, that they don't need it. And then they're also rewarded by, hey, they're good, they do good without the drug too. So there's some psychology, at least in my thinking. We'll see what Evelyn and the psych team think about that. So communicating with the patient, shared decision making. Going back to our patient at the beginning, this is one where I probably won't make any changes on their first visit, simply because I'm trying to develop trust for the patient. Because I don't care how good of a plan that my resident or my fellow will create for this patient. It's like, so what if the patient doesn't come back a second or a third time? And and by the time they come back to me, and we've seen them 5 to 10 times, my plan's always always evolving, always different as I'm tailoring it to the patient's unique need. And so a lot of times setting both short-term and long-term goals with the patient with pain, it's people tend to be older and it's invariably they want to spend time with their grandchildren. And so we know they're just going to have a little bit more pain on that day and have a recovery day from it. But those are some of my, and then we can start, once we ask what that functional pain goal is, what sort of therapy, what sort of modality do we need to to bring on board to help with that? As far as what's taper first, this is I asked my patients, which one do you want to taper first? Hopefully nobody's on crisaprotol or the trade name is Soma in 2024. It's a drug I wish would just be taken off the market. Start taking your long acting meds off, and then with our short acting, I tend to come off the opioid first, just because if they're on an opioid use disorder, I can kind of titrate down, and I've got other drugs that I can treat with the pain. Getting them off the benzodiazepines, like I said, is really tricky. And I want to have trust in the patient on the benzo approach. But whatever the patient's willing to come off on, that's what I'm going to go with first. All right, this is just some different thoughts and more on a table form on if they've got a substance use disorder, like let's immediately get in and transition them to treatment. If we have diversion, this one's an interesting one. I think in 2024, if they have an opioid use disorder and we think that they're diverting, I take each case as a individual, as a case-by-case basis. But a lot of those people I now either do daily dosing at the window, which at a methadone clinic I've got the option of doing, or we have the injectable products of Brixadi and basically that eliminates the diversion. If they and I think the other ones, again, it's a bit of a case-by-case basis. Why are they doing it? He basically worked as a truck driver. He's a little obese, and I think he just has some chronic back pain. He doesn't have any numbness or tingling that we would need anything particularly for. He's we'll just say he's had some MRIs that have been done over the years that just shows arthritic changes. All right, so on this case, this is one where we elected to decrease by about 10% of the original dose and coordinate specialists as need be, and create a support network of non-opioid care. I'm a big supporter of, especially for when it comes to back pain, for acupuncture. I think it's mind-boggling that in 2024 with the CDC guidelines that we don't have Medicaid, Medicare reimbursement for things like acupuncture that have been robustly studied in peer-reviewed literature for back pain. I also would support to some chiropractic for some relief of pain. Again, if it doesn't work, it doesn't work, but at least we're trying some other non-opioid type things that does have evidence behind it. We'll look to consider, again, with some opioid tapers. So again, back to the case, we had individual buy-in, and the patient actually did really well with the TENS unit. I think going to Donna's point on what the underlying cause here is, we get into this reflux arc of these back spasms, which cause pain, which cause more spasms. And if we can just put a TENS unit on and really fatigue or wear out those muscles, we get our alignments, and we break that cycle. And it was also started on duloxetine. I think just a reminder of depression that is oftentimes co-occurring in people with chronic pain. Again, I use the example of natural childbirth, but if my back hurts and I can't go to work every day and I can't get outside and enjoy the yard work and suffer allergies on the back end, like that's just a depressing lifestyle to be thinking about, where I'm just binge watching Netflix. I mean, is there really that much content on Netflix? So I think sometimes having something to manage the co-occurring things help. Also, the fundamental science is fundamental science, and the Pavlov and his dogs. And I know if I move this way, it hurts. And then we become triggered just thinking about having to move that way. And then an exaggerated feel for pain, and then the exaggerated pain when coming off of meds. Last slide, and I know we'll just shout out to Donna because she's brought this up in the past too, is the importance of our self-care. I think sometimes these taking care of patients and cutting down can be challenging to us as individuals. Make sure we're grounded, because if we're not, then our biases start coming out, and we're not making the best decisions, I think, for our patients and ourselves.